Okay, good evening, everyone. My name is Betsy Torres. I'm the Associate Director of the Office of Continuing Professional Education. And thank you for joining us tonight for COVID-19 and the Optometric Community webinar part 2. Tonight's webinar is brought to you by SUNY College of Optometry, and we're going to introduce Dr. Richard Madonna right now to begin the conference. Dr. Madonna?
Thank you, Betsy. Hi, everyone. I hope you're well. We have a lot of content for you tonight. Last week, we had literally 500, 600, 700 people on, and I think we may have even more tonight when all is said and done. What we thought we would do this week is to look more at the science surrounding this infection. Our speakers are Dr. Ann Beaton. Dr. Beaton is, all members are faculty at SUNY, by the way. Dr. Beaton has a PhD in Virology and Molecular Biology from Cornell, and she teaches in that space at the college. She'll be up first. She'll be followed by Kim Poirier-Schmidt. Dr. Poirier will be speaking about the some of the papers that we've seen regarding the eye and this infection. Third, Dr. Anu Lal, who is amongst many jobs at the college, is the chairperson of our infection control committee. So he'll be speaking about infection in the office. After that, Dr. Matt Bovenzi. Dr. Bovenzi is Assistant Chief of Primary Care and has experiences in a lot of different clinical areas. He'll be speaking about emergency care and some of the telemedicine that goes with that. And finally, Dr. Richard Soden, we've asked Dr. Soden to come back because since last Sunday night, when he gave you that excellent presentation on billing for telemedicine, things have changed dramatically. So we thought it appropriate that we bring Dr. Soden back. So those are our 5 speakers tonight. Again, I want to thank Betsy for the time she's put in to make this happen, very short turnaround, and for our speakers who, again, only had a couple of days to prepare for this. So we really appreciate their time as well. What we'll do is they will each speak in turn, send questions when you have them. But we will hold all questions to the end, and we'll do what we did last week, where I will read the questions and our speakers will answer them. I would ask that if you have questions, you do not send them in the chat box, but send them in the Q&A box so we can keep track of those. If you have other things such as my audio is not working, those sorts of things, please you can put that in the chat box, or if you just want to say hello, you can do that as well. And we'll remind you of that again as we go forward. So again, thank you all for being on. The college is determined to try and keep everyone abreast of what's going on with COVID-19 and how it affects our community. So with that, I am going to hand it back to Betsy. Unless Dr. Beaton is just going to jump in. Betsy, it's all yours, or Ann, it's all yours.
Okay, so Dr. Beaton, as you can see, Dr. Beaton, there we go, great. Thank you, Dr. Beaton. You can start to share your screen.
Okie dokie. Everybody see it?
Yes, we do.
Terrific. Okay, there we go. So, good evening, everyone. So I just want to thank Dr. Madonna for asking me. It's unusual for the sciencey girl to be asked to do these things. So I just want to say that being asked to do CE for the college is like when the nerdy girl gets asked to the prom by the hunky popular boy. So I'm glad to be that nerdy science girl today for you. Okay, so let's start off by talking a little bit about the nomenclature, because there seems to be some confusing terminology. So what we've been calling COVID-19, is the disease, but the virus that causes it is actually called SARS CoV-2. Okay, so coronaviruses in general are enveloped RNA viruses that are the second leading cause of the common cold worldwide. They're responsible for about 10 to maybe a third of the cases of colds. But until the early 2000s, they really weren't known to cause any serious disease. We know now that there are 7 human coronaviruses, and that most of them up till this point actually followed a seasonal pattern very similar to influenza virus. Oops. Whoa. So where did this virus come from? So lots of coronaviruses circulate among animals, and they include bats and camels and all kinds of interesting animals. And they're considered to be what we call zoonotic, meaning they can be transmitted between animals and people. Most of them only infect their particular animal host, but you can occasionally get crossover from animals to humans. So the first such crossover that happened that we became aware of occurred in 2002 to 2003 with the event of severe acute respiratory syndrome, or SARS, caused by SARS CoV-1. So this virus had a reservoir in bats. Oh, I don't know why that's happening, sorry. And it crossed over into civet cats, as you can see up here, and then crossed over into humans. It affected 26 different countries. There were more than 8,000 cases, and it had a pretty high mortality rate with 800 people dying from it. And then in 2012, we saw Middle East respiratory syndrome. And this was a virus that appeared in humans, again in a species jump. This time it came from camels. And this disease had a very high mortality rate, killing about 30% of the people that it infected. And now we come to SARS CoV-2. So I just want to say right off the bat, there have been some sort of conspiracy theories out there about how the virus was actually constructed in a lab or otherwise engineered. But the entire viral genome has been sequenced. And from the data, it seems that the virus actually jumped from bats, then transferred to pangolins, this little guy over here, and then subsequently adapted itself to human hosts in that open air market somehow in China. It's interesting that bats are the reservoir for so many different viruses, and deadly viruses at that, think rabies, without any deleterious effects to the bats at all, meaning that the bats must have some really unusual and tolerant immune system, but clearly that's a story for another day. Okay, so everybody's been seeing these pictures of coronaviruses. This is the coronavirus here. And you can see the familiar, everybody's seeing this on the background of every newscast, every show, with its club-shaped spikes on the surface, right? So these spikes, look like a solar corona, hence the name coronaviruses. And the actual protein that's sticking out here is present as a trimer of 3 proteins together, is called the spike glycoprotein. Now, it sticks out through this outer part of the virus, which is called its envelope. So in other words, when coronaviruses leave a cell in the course of infection, they actually take part of the cell membrane with it. And then they insert their own proteins within that cell membrane. Now, though it sounds like having this extra cell membrane around, it affords the virus kind of this extra layer of protection. Actually, it's the other way around, that this lipoprotein membrane, which actually comes from cells, actually makes the virus more labile and easier to disrupt with chemical and physical agents such as soap and water and alcohol-containing sanitizers. Then within the virus envelope, right, you have the capsid. That's this kind of red thing here. It's not really showing the envelope. And then inside that, you have the viral genome, right? In this case of coronaviruses, that genome is actually made up of RNA. Now, the significance of it having an RNA genome is that in general, viruses with RNA genomes are more variable. The enzymes that replicate RNA polymerases, lack proofreading functions. Think spell check. So most in our cells, when our DNA replicates, the DNA polymerase actually checks that it's put in the right nucleotides. So that means that RNA viruses are in general much more variable than any virus or cell that has DNA as its genetic material. A great example of this variability is seen in human immunodeficiency virus. So in the early days of HIV, when there was only one drug to treat the virus mutated rapidly and became resistant to it. Later on, we started to implement triple therapy, which meant that the virus didn't replicate much. In other words, not lots of changes occurred to the genomes, and they don't become resistant quite as quickly. Interestingly, among RNA viruses, coronaviruses are relatively unique in that their RNA polymerase actually does have some proofreading ability. And this is one of the reasons why there's not a lot of new variants that arise, although even with a proofreading capability, some mutants do escape the scrutiny. That being said, there's very little evolutionary pressure on this virus to change. It is already a very successful human pathogen, as we know. Okay, so the the coronavirus, again, you see here in the upper left with this is kind of a little cartoony thing, it has its spikes on the outside. So what do those spikes do? Those spikes actually attach to receptors on human cells. And in the case of coronaviruses, that receptor is the angiotensin converting enzyme 2 protein that sits in the cell membrane. So the virus sticks to that cell membrane, right? And of course, we know what ACE does, right? ACE2. The ACE2 protein cleaves angiotensin 2 into a vasodilator, angiotensin 1-7, and this contributes to reductions in blood pressure. So coronaviruses can only enter a cell when the two connected halves of this spike protein are cleaved by a human enzyme, and that human enzyme is called furin, which is found in many, many tissues. The virus and cell envelopes fuse, so that's what you see here, and the receptor virus complex is brought into the cell. The virus uncoats, releasing its RNA genome. The RNA genome serves as messenger RNA, gets translated into proteins, gets copied into new viral RNAs. It assembles in the cytoplasm of a cell. It sticks a new spike protein into a membrane when it departs, and here you see it assembling. It goes to the virus surface, and then it buds. And again, as I said before, when it buds, it takes a piece of the cell membrane with it, and it sticks that glycoprotein, that spike glycoprotein, through that membrane. Here on the right, what you see is a representation of the binding of the ACE2 protein to the spike protein on the virus. So one question you can ask is, how does this virus actually cause disease, right? So it first infects ACE2 cells that line the upper airways, kills those cells, those dying cells slough off, and they fill the airways with dead cells and debris and carry the virus deeper into lungs, where it binds primarily to type 2 pneumocytes. This is a type of cell that lines the alveolar septa. You don't have to be a histologist to look at the difference between what you see on the right here, which is the open lacy network that's seen in the lung, versus what you see on the top 2 sections here, where those alveoli are filled up with either dead cells or immune cells. As the infection progresses, the lungs get clogged with the dead cells, and fluid gets released from the cells, making breathing much more difficult. Now, all viruses, and coronaviruses are no exception, encode gene products that co-opt the cellular machinery in order to complete their replication, but also to avoid the host immune response. So SARS CoV-2 encodes a protein that blocks the infected cells from sending out signals to the immune system, although eventually the presence of virus does induce an immune response. So again, now in addition to getting these dying cells in the alveoli, you get inflammatory cells that are arriving to fight off the infection and kill the virus. And while the immune response is generally highly controlled, it can sometimes go berserk and damage healthy cells as well. And I'll come back to that in a minute. So I just want to point out a couple of things that are not really well understood about SARS CoV-2 pathogenesis right now. Among them, why some people who get the virus get serious and deadly illness, while others have inapparent infections and have very little to no symptoms, and who in fact may be an important source of community spread of the virus. Then this is behind the new recommendations for everyone to wear some sort of face covering while out, for fear that people who aren't sick are actually spreading the virus. So I just want to leave you with the notion that consortiums like the COVID-19 Host Genetics Initiative are bringing together the larger human genetics community to generate, share, and analyze data to learn what's different about different people. What are the genetic determinants of COVID-19 susceptibility, severity, and outcomes, and why even, for example, men seem to have worse outcomes than women. And another unknown is whether the more virus you're exposed to, like if you have someone who really coughs in your face versus being in the same room with someone or within 6 feet and you just get a very small dose, what your outcome and how that outcome will differ. Okay. All right, so how do we defend ourselves against viruses in general and about this particular virus? So here I'm representing your host defenses as a series of barriers that the virus has to get across. So many infections are prevented by anatomical and chemical barriers. The first barrier you see here, and that includes, of course, intact skin being one of those, that being one of your best friends, intact mucous membranes, and even your tear film. Also, your normal microbiome, the bacteria that sit on your skin and in your mucous membranes, prevent viruses from binding to receptors because they're already blocking those receptors. Now, if that first barrier gets breached, right, the virus now has access to your cells and it binds to receptors on the cell surface, right? So that the ACE2 protein is the SARS CoV-2 receptor exemplifies the fact that viruses bind to molecules that have otherwise normal cell functions. The receptors aren't there for the viruses to bind to, they have real jobs to do, right? Okay, so the next barrier is your innate immune response, in which cells have receptors on their surfaces that detect invaders. One example of those kind of receptors are called toll-like receptors, and what these do is to recognize molecules on pathogens that aren't present on normal cells, and they bind to them and then initiate an inflammatory response. Your innate immune response is triggered very quickly, and its main job is to prevent spread and movement of pathogens throughout the body. Think of innate immunity like first responders, right? So sometimes they can rescue someone without further help, but sometimes they need additional aid. Cells of the innate immune system can eliminate potentially harmful antigens, but they also inform the next level of barrier, the adaptive immune response. Innate immunity induces the synthesis of lots of cytokines. These are small proteins that play an important role in coordinating and regulating the immune response. And these cytokines, in fact, recruit more cells like neutrophils, polymorphonuclear leukocytes, and monocytes to the site of infection, and these secrete even more cytokines. So cytokines include molecules we've all heard about, like interferons and interleukins, and especially in the case of interleukins 1 and 6, which among other things induce fever, it's the uptick in these cytokines that make you feel sick when you're experiencing a viral infection. An outpouring of cytokines in response to COVID-19 may cause what is called a cytokine storm that can damage the lungs and other tissues and cause respiratory failure. And because cytokines can travel anywhere, they can induce systemic symptoms and cause harm to other organs, leading to multi-organ failure. So the innate immune system holds things in check until the adaptive immune system kicks in, which can take a few days and up to a week or two to start going full steam. The adaptive immune response results in antibody-producing B cells, as well as T cells that are in the cell-mediated immune response. While innate immunity is not pathogen-specific, adaptive immunity is very specific, and probably most importantly, it remembers previous encounters. And this memory can result as experiencing pathogen exposure or as the result of immunization. So both previous exposure and immunization will result in the production of memory cells that can quickly respond if you experience that pathogen again. Now, the last thing I want to say about this is that your immune system is your friend, but is sometimes also your frenemy, your friend and enemy, because many signs and symptoms of the disease are caused by your immune response. So think here, fever, tissue damage, aches, pains, nausea, and an overblown immune response can be the cause of a lot of damage to tissues. So there are trials going on now using monoclonal antibody antagonists of the pro-inflammatory cytokine IL-6 in both the United States and in Italy as we speak. Oh my God. Okay, so there's been a lot of talk about testing for COVID-19. How is it actually carried out? The first and currently the most widely used test is using what we call real-time reverse transcription. So this is a qualitative test looking for the presence of viral RNA. So what they do is they break open the virus, they copy that RNA into DNA, and they do that because RNA is a lot harder to work with, and then they use the polymerase chain reaction to greatly amplify the presence of that nucleic acid. So you've seen the pictures and on the news, they stick a swab way up your nose, right? And then they have to isolate the viral RNA from that swab. The test in the lab, they take it back to the lab. It takes a few hours to carry out. There is a relatively new test that's been produced by Abbott Labs that also works kind of similarly in that it has to recognize the nucleic acid, it has to amplify it, but the good news here is that this approach is very inexpensive and it can be done. You get a positive result in as short as 5 minutes, a negative result in 13 minutes. The instrument is the size of a toaster, and it's highly portable as a result. And then the last thing I'm going to talk about are antibody tests. So these are, again, relatively new to the testing scene. And what they're doing is looking for antibodies to confirm either current or past exposure to the virus, and work in as little as 15 minutes. The test is like a pregnancy or one of those rapid strep tests. What you do is get a finger prick from someone. So again, much less invasive, actually less worrisome for the healthcare worker, because they're not having to, breathe, get close to you and breathe in, be by your nose and mouth. You get a finger stick, you put some blood in here with a little buffer, and that wicks up, and it will show you whether you have produced IgM, IgG, and of course they have to have a control. If this line doesn't show up, then the test didn't work right. So why are they looking for these particular antibodies? IgM, the appearance of IgM occurs very early in the course of an infection. It's the first antibody to appear. So if you only have IgM, it means you have recently been infected, right? IgM only hangs around for about 60 days. So if you no longer have IgM, it means you've really, been, past the point of infection for quite a while. IgG comes up a little later and lasts much longer. Many companies are beginning to ship these kind of antibody tests as we speak, and they should be able to ramp up supply relatively quickly. Okay, so what are some of the treatments that are being talked about? So probably everyone has heard about the use of chloroquine phosphate and hydroxychloroquine sulfate, which have been previously been given approval by the FDA, but for other things, but they've been given EUA, Emergency Use Authorization, for COVID-19. So these have been previously approved for treating malaria, for extraintestinal amoebiasis, and for treating lupus and rheumatoid arthritis. So we know something about the safety profile of these drugs because they have been FDA approved for certain other indications, but these drugs are not without serious side effects such as hypoglycemia, heart failure, and even retinal toxicity. Now the trials for these drugs are really not that great so far. There's only really one well-controlled study that's been published in China where 31 patients were in the control group and 31 in the experimental, and they measured what they call TTCR, time to clinical recovery, and they found that the treatment group, the time to clinical recovery was actually much shorter. So maybe there is something to that. Okay, another treatment is the use of COVID-19 convalescent serum. So what that is to collect, you collect serum from patients who have recovered, right? And give them what's called passive immunity. So passive immunity is the administration of preformed antibodies, and it's something that confers immediate protection, but it's not long lasting. Like if you produce your own, immunity, then you have memory cells so that if you see it again, you're protected again. This is short-lived, but it protects you immediately. So what they do is they get donations of convalescent plasma from people who have recovered. They have to be fully recovered for at least 14 days. And the eligible patients for this have to be severely ill, with life-threatening illness. So this use of convalescent serum isn't new. It is a tried and true method that has been used successfully for many infections, including for Ebola and for rabies, right? One thing that's come out of this is, and this was done for Ebola virus, is that they actually made recombinant antibodies so that you don't have to collect serum from a patient. You make recombinant, using recombinant DNA technology, you make antibodies that are, that will be useful against COVID-19. And then finally, antivirals. So drug companies are combing through their formularies, looking at drugs that are already used as antivirals and shown to have efficacy. So we have antivirals against HIV, we have antivirals against hepatitis C, and they're looking for ones that might, work against this virus. And one that has received some press is one that's called remdesivir, which was originally intended as a treatment for Ebola. Okay, so the question is, when will this end? What will end this? So we have to decrease what's called R0 to less than 1. So R0 is the number of cases on average an infected person will cause during their infectious period. It's affected by the properties of the pathogen, such as how infectious it is, and of course by the host population for how susceptible is the person that is exposed to it. An outbreak will be expected to continue if the R naught is greater than 1 and to end if it's less than 1. So this is the concept behind social distancing in the long run, to decrease that R0 to less than 1. Although in the short run, social distancing is really about keeping the number of infected persons low enough to allow our medical system to not become overwhelmed. So spread of a contagious disease within a population will stop when there's a sufficiently high proportion of people who have become immune to the disease, either by natural infection or through the use of vaccination, right? And this concept is called herd immunity, right? So everyone who's had COVID and even those who have inapparent infections will be immune. And this will add to the number of people in that herd that have herd immunity. And these people can't spread it to anyone else. So it's generally thought that about 80% or more of the population has to be immune for herd immunity to be useful, although that number can be much higher for other diseases. So if you think about measles, for example, it's thought that in order for a measles epidemic to be contained by herd immunity, around 95% of the people have to be immune, either through having previously been exposed or by vaccination. So another way to get herd immunity is, as I just said, by vaccination. So there are 2 main vaccines that are being tested right now against SARS CoV-2. There's a trial underway in Seattle right now using an RNA-based vaccine. And the idea here is to give patients a vaccine that contains the RNA that encodes the viral spike protein. You get it inside someone's cells, and once inside the cell, your cell does the work of making that RNA into a protein and still recognizes it as being foreign and activates the immune response to make antibodies against it. And the second vaccine in trials is built around an engineered version of adenovirus, another cold-causing virus that has been disabled, so it can't replicate. And now what they've done is using recombinant DNA technology is to stitch into this vector a gene for the surface protein. And this vaccine is actually being tested in monkeys as we speak. And I just want to leave you with how will this really end? It'll really end through science. So this came from the Milken Institute's website. So you can see how many different avenues are being looked at right now for treatments or vaccines. So 49 different vaccines, lots of different types of antibodies, antivirals. So that is what in fact will get us out of this big mess. So I just want to leave everyone with the advice to be well. We're being asked to make the sacrifice of staying home and sitting on our couches. We should think of those in the trenches. So we want to lower the curve because we don't want to have an alert kitty outbreak, that'll shred the healthcare system. But we'd rather see this lazy kitty, right? So that we get long intervals between transmission events so that our healthcare system can deal with it. So that's the science end of things.
Okay, great. So we're going to go on to our next speaker. And I'm going to just share my screen momentarily while she sets up. So this will be now Dr. Kimberly Poyer. Dr. Poyer, are you online?
Yes, I'm ready to go.
Okay, great. All right, great. I'm sorry, Poyer Schmidt. Sorry about that. You can start sharing your screen now if you're available.
Okay. All right.
Thank you, Dr. Beaton.
Thank you, Dr. Beaton. And I hope that everyone can see my screen. I'm going to take it that you can.
Yeah, we can. I'm confirming you can, and we hear you loud and clear.
Excellent. Perfect. So I'm going to be discussing some of the ocular manifestations of COVID-19 or the SARS CoV-2 virus. There really isn't too much research out there yet. So what I decided to do is to go through the few studies that are available and just kind of extract some of the data that I think would be important to optometrists and for some good information to disseminate to you all. Okay, so first and foremost, this is probably one of the first studies that was put out in JAMA Ophthalmology, just regarding the characteristics of the ocular findings of patients with coronavirus disease. This was in Hubei province in China. It was a retrospective study, and it was from February 9 to 15th in 2020. So recent study, 38 patients, so a very small cohort of patients. And 28 of those patients were COVID-19 positive. So they did have the virus, and that was tested via nasopharyngeal swab. So about 30% of the patients that did have COVID-19 showed some ocular manifestations. And through this study, they saw that most of these patients that had ocular manifestations had conjunctivitis, so your viral conjunctivitis, conjunctival hyperemia, chemosis, and epiphora. So just kind of your, run-of-the-mill, so to speak, viral conjunctivitis manifestations. And this is a table that was extracted from the same study, some characteristics of the patients that were COVID positive or were positive for the virus that had the ocular manifestations. So I think the important thing to take away from this study, I'm just going to summarize it all because I don't want to take up too much of the time, but what I thought was the most important was that the ocular manifestations, they were mostly seen in patients that had severe pneumonia. So these weren't our patients that, had very mild symptoms. It wasn't in the patients that, were asymptomatic. So really the ocular manifestations were seen in the more severe cases. So, usually we won't be seeing these patients, hopefully, right now in our practice. However, some of you may be practicing in a hospital setting, doing, rounds, going to rooms, the ICU to do different ocular consultations. So just know that the ocular manifestations are usually more in the severe cases. 16% of those patients that had the ocular manifestations showed the virus in the conjunctival swabs. So really kind of a low amount of virus, a low amount of patients actually had the virus in their ocular secretions. So very low prevalence. However, the transmission through the ocular tissues was possible. And that was just the conclusions of this study. So ocular manifestations, viral conjunctivitis with severe cases, but a very low prevalence in the ocular secretions. But they couldn't really rule out that ocular transmission wasn't possible. All right, so moving on to another study. So this is the second of, I guess, 3 that I'm just going to touch upon. So this was an evaluation of coronavirus in the tears and conjunctival secretions of patients with the viral infection. So in this study, again, it was a very small cohort of patients they had. So they had tear and conjunctival secretions of 21 patients that were COVID-19 positive, and they were collected for the viral cultures, and they used the RT-PCR assay on these patients. And they were looking for presence of the virus in the tears and in the conjunctival secretions of these patients. So they really wanted to know, how exactly is this virus? What is the transmission route of this virus? Is it in the tears? Can it be spread from the tears or the conjunctiva of a patient into the doctor that is performing their examination, or does it not? So they really wanted to know what is the risk of infection for their doctors that were treating these patients. So the results of this study, again, it's a small study, but it was a little bit better controlled, and they were able to take more samples of tears and conjunctival samples from these patients than the previous study. So the results were a little bit better than the previous one. So the results that they found were that no viral particles were detected in tears and conjunctival secretions of patients without a conjunctivitis. So these patients didn't have any viral particles when they weren't really that sick. And also they had to have some sort of ocular manifestations or conjunctivitis to have viral particles. There were some small amounts of virus found in tears and the conjunctival secretions in the patients with conjunctivitis only. And so with this study, again, a little bit better, they still couldn't really rule out ocular transmission of the patients from tears and conjunctival secretions. Okay, on to the newest study, and some of you may have seen this in a recent email from the Academy. So it was a new study that's actually going to be out to press. It's in the March 2020 issue of Ophthalmology. It's very new. The whole study isn't actually published yet, so they're very preliminary results. But what this study found are tear samples from 17 patients, so still not too many patients. It is a small number of patients. However, the good results of this, the study was designed a bit better because they were able to follow these patients for a longer period of time, from day 3 to 20 of their active symptoms. So they got much more samples. They were able to sample the patient's tears and conjunctival secretions from having minimal symptoms to being extremely symptomatic, and then again while they were recovering. So they had a much better data sampling from this cohort of patients. And what they found, again, preliminary results, but they did find that no evidence of virus in tear samples, therefore low risk of ocular transmission. All right, so what does that mean for us? So I'm going to kind of take all this information, just kind of summarize it again, and then give you guys some tips and tidbits of how to apply this into practice as well. So again, in conclusion of this particular part of my talk is the ocular manifestations of COVID-19, just as a review. Conjunctivitis or viral conjunctivitis is the primary ocular manifestation that we would see. Conjunctival hyperemia, chemosis, and epiphora. And typically, these ocular manifestations are only in symptomatic COVID-19 cases with pneumonia. A very low abundance of the virus found in tear and conjunctival secretions of these patients, and overall, fairly low risk of virus transmission through ocular secretions. So, even though it is low risk of transmission from your ocular secretions, it still doesn't get rid of the risk of having patients' aerosols. So, from spit, coughing, sneezing, that particles, they can also enter through the eye, into the provider's mouth. So, and we work so closely with our patients all the time that we really have to be careful, have the proper PPE. And I know Dr. Anulal, is going to be discussing that in a few moments, so I won't go into that. All right, so optometrist considerations. So some things to consider. These are some questions that you'll probably get as providers from your patients. Of course, contact lens. A lot of our patients wear contact lenses. We wear contact lenses ourselves. And just kind of be able to educate our patients. Will the virus be contracted? Are they able to spread the virus through their contact lens use? And really they don't, because there is not much viral particles or little to none found in the tear secretions. So what do we tell our patients? Good hygiene, that's first and foremost the most important thing. Follow CDC guidelines, make sure we're washing our hands for 20 seconds, saying happy birthday or whatever song that lasts about 20 seconds or so with warm water. And then, trying to educate our patients to use daily disposable contact lenses if possible. Try to reduce the amount of time these lenses are sitting in their solution. So daily disposable would be preferable. No top up or reuse of solutions, making sure you replace the cases monthly or even more frequently just to prevent any type of ocular infections. And of course, these are all good to educate all of our patients that wear contact lenses, but it's always good just to remind them, just to have extra hygiene in these times. And also do not wear contacts if they're ill. So if a patient is not feeling well, fever, flu, COVID-19, we did from the studies what we've seen is that patients that do have viral particles are typically the ones that are sick and the ones that have a conjunctivitis. So if they're not feeling well, just do not wear contact lenses, just stay in your glasses. Another consideration for optometrists would be to wear PPE while examining the patients. And again, even though the tears and the ocular secretions aren't necessarily ways we can get the infection, however, it is important for us to protect ourselves from our patients sneezing in our faces, which would not be a good thing, which is to make sure that we don't get any mode of transmission ourselves. So really, PPE is very, very important, and Dr. Lal, again, is going to be discussing that with you all in a moment. And last but not least, I just wanted to kind of reiterate or piggyback on from what Dr. Beaton was discussing regarding COVID-19 treatment and the use of hydroxychloroquine. One of the better RCTs or randomized control studies that are occurring is with hydroxychloroquine, which I know has been all over the news. And I just wanted to make the note of retinal toxicity, because I'm sure, we're thinking about it. Do we need to be screening our patients more for any retinal toxicity if they were treated with hydroxychloroquine? In this study, but the amount that they've used in the study was 400 milligrams a day for 5 days. And I just wanted to reiterate that usually when we have retinal toxicity, the dose and the duration are the most important factors when we're considering retinal toxicity. So, these patients aren't really treated long enough to develop any type of retinal toxicity. So hopefully, we obviously don't have data yet, and we don't have any patients that have really been on this treatment successfully, so to speak. But just know, the dose and the amount of time that these patients are on within this RCT, this trial, is fairly low. So I think the risk of any type of retinal toxicity in this case would be low. All right.
Okay, so we are going to move on to our next speaker. And our next speaker.
Betsy,
yes?
This is Dr. Madonna. I'm going to ask, I just sent you a text, but I'd like to step in here.
Oh,
I think in looking at the questions that have come in, I think rather than waiting to the end, it may be reasonable, because the questions are very specific to the talks that Dr. Beaton and Dr. Poirier have made, that maybe this is a good idea rather than waiting to the end to get at some of these now, if that's okay.
Okay.
Yeah, I think it may be, because there are some very good questions, and rather than waiting. So I'm going to just start at the top, and Doctors Beaton and Poirier, if you're ready to roll. The first.
Okay. So what I'm going to do is I'm going to put the slide up that just says COVID-19 for now, so that people are not just staring at a news picture.
Okay, he's a handsome guy.
All
right. So here's the first question: are different blood types affected differently by this virus?
So the answer to that is anecdotally, it seems like Group A has higher risk and Group O has lower risk.
And is there any reason you can think of why that might be the case?
I don't. Yeah, I have no idea.
Okay, the next question is, if you take an ACE inhibitor for blood pressure, do you have greater protection against the virus?
So, that's there's a lot been written about this, and it's kind of, controversial. So, they know that, for example, treatment with intravenous ACE inhibitors increases ACE2, the receptor for the virus. And so that they're worried that, maybe that would give the virus more portals for entry. We do know that there's more severe disease, obviously, in hypertensive patients, but really all we know right now is that doctors are recommending that hypertensive patients should not stop taking their drugs. So that's, really where we are. And I think that there are a lot of studies being done right now. And the answer is, I don't think anybody really knows well.
Thank you for that. The next question is, and I assume this goes to some of the studies that you talked about, Dr. Beaton. Do we have any information on the sensitivity or specificity of these tests?
Yes, off the top of my head, I don't know, but most of them are pretty good. Their specificity, they're good for the most part. There are some false negatives, but not a lot. And I think that the tests are getting better and better.
Yeah, and I would assume that the sensitivity and specificity will increase as the number of patients who are in the study.
Absolutely.
The next question is, can you address those who've had COVID and been reinfected? I think that's a wonderful question and an important one.
Yeah, I mean, again, so a lot of these, and this is probably not things that people are going to want to hear, right? So I think a lot of cold viruses, this is true of rhinoviruses, and it appears to be true of some of these coronaviruses, that even if they've come up with a vaccine, you may not have long-lasting immunity. And it may not be what we call sterilizing immunity that will actually prevent disease, but it'll be the type of immunity that will make it sort of more like a common cold. So I think that, again, these are anecdotal. We don't have really large studies on, patients becoming reinfected. So there's not a lot of good data out there, but I think we can expect that there's going to be, this is going to be a seasonal virus eventually, that we're going to have some treatments for it eventually that will make it tolerable, but this is not going away forever. This is not smallpox, is what I'm trying to get at, which we eradicated. That's not going to happen.
The next question is, can you speak about recent tests regarding the antiviral properties of ivermectin, the antiparasitic that eradicated river fever?
Yeah, so what I've read about ivermectin, which is used as an antiparasitic drug, is it actually prevents the virus from having a negative effect on your immune system. But again, this is not well studied yet, and so what's out there is really anecdotal, and there's not been, for example, a controlled study.
Thank you. So, the next question, I believe this is for Dr. Poirier. Was there a correlation between high viral load and more disease severity? And Dr. Beaton spoke about that. I assume this question then is aimed at the ocular manifestations as opposed to what Dr. Beaton talked about.
Right. So, I mean, with the studies, like there's very minimal information out there, and unfortunately, they weren't really specific studies. So, in the very first ocular manifestation study, they didn't test the specific viral load. They just test for the presence of the virus itself and kind of correlated to the ocular manifestation. So, there wasn't really a correlation between severity with respect to the actual viral load, but there was a correlation with the ocular manifestations and pneumonia is what they found. So I guess technically speaking, I guess the viral load probably may be higher, but it's unsure because it really depends on everyone's differing immune system response, I guess, to the virus.
And it's not really well understood again about the dose response. So if you get a whopping, inoculum of virus, whether you're going to have worse disease than someone who doesn't. It's just, again, it is not known yet.
Mm-hmm. Exactly.
Again, Dr. Poirier, are the ocular symptoms typically binocular?
So again, there really wasn't much data out there. So they did note in that study that a lot of their outcomes or manifestations that they recorded were, they weren't really able to examine the patients properly or closely. So they didn't specify if they were monocular or binocular, but I can assume probably, since it is a systemic disease, that both eyes are probably affected if the patient does have any ocular manifestations. But it wasn't clear from the study, so it's a good question though.
I think this is referring to hydroxychloroquine. Is the dose split to QD, BID, or TID? I believe that's what that question was about.
I'm not sure specifically. I don't know if Anne, if you had it in yours. I believe it was just once a day. I don't think the study though specified the actual.
Yeah, I don't know either.
Mm-hmm.
Okay. The next question was about PPE, so I'm going to hold off on that one because I think Dr. Law will be addressing some of that. The next question again, Dr. Poirier, what's the treatment of COVID-19 induced conjunctivitis?
Right. So I guess with the viral conjunctivitis, they didn't specify in the studies that I've read. However, just kind of thinking with a normal run-of-the-mill viral conjunctivitis is what it sounds like. So I believe that it would be, self-limiting. And they did find in that last study when they were, testing the viral presence in the secretions over time, that it did lower, it did reduce over time. So I would assume it just would self-limit, not in just kind of supportive therapy if needed. But a lot of the times these patients are very sick, and it's probably the last thing they're thinking of. But
yeah. Yeah, could I, oh, thank you. Betsy just sent out there, but I'm going to say it. Please try to send your questions into the Q&A box, not the chat box. I saw them come into chat, so if you did send one in there, I'll get it, and I have it, but it's easier for us if it comes into Q&A. Thank you. The next question.
Yep. Oh, wait, I want to say one thing. If for some reason you don't have access to the Q&A box, email them to ce@sunyop.edu, and I will somehow try to enter them into the Q&A box so that Dr. Madonna can read them in that order.
Great.
Try not to put it in the chat box there, so this way we're not bouncing back and forth. Sorry, Dr. Madonna.
No, that's okay. Thank you for that. The next question is, among the people who recovered, was it their own immunity that helped them, or was there a treatment used by a large number of physicians that seems to have worked? Hydroxychloroquine has not been universally accepted as a treatment modality. APN01 is now being tried at the epicenter of the virus in Europe. Any thoughts?
So I just want to say that for the most part, these patients are, most of the patients who are very ill are being treated supportively only. And so it has to be their immune response that's making them well. There's not a lot of patients in these hydroxychloroquine studies.
Thank you for that, Dr. Beaton. Here's one, that we hear a lot about. Has it now been determined whether or not ibuprofen makes COVID-19 worse? There's been a lot of speculation out there about it.
Okay, so I just, listened to something about that yesterday. So there's a controversy over the use of NSAIDs, of course, to reduce fever. We know that fever is an innate immune response, and some people don't want to reduce that at all because, if it's part of, your innate immune response, do you really want to tamp it down? And again, there's been more specific things that have been said about not using ibuprofen in particular to control fever in COVID-19. But what I've heard is that, critical care doctors are saying that, fever increases cell metabolism. That increases the level of carbon dioxide, and not reducing the fever may further diminish the already critical levels of oxygen saturation and the ability to keep COVID patients well oxygenated, especially those on ventilators. So I think that this is a part of the clinical care recommendations that will continue to evolve as we know more and unfortunately treat more patients. So it's still up in the air. I think they're recommending that, these patients who are critically ill are being given NSAIDs, right? And they're saying for people at home who are feeling ill that, maybe if you needed to sleep, you should take it at night, but try to avoid it perhaps during the day. But it is not healthy, or it's not good for you to have a ragingly high fever.
Thank you. That has been all over the news quite a
Yes.
bit. Dr. Poirier, I read lid erythema was a common COVID-19 symptom. Is that true?
So, I've read that as well, but I haven't read that in context of a study. However, I guess it would make sense. Lid erythema would also be tied in with having, conjunctivitis and your immune response as well, kind of the whole eye being affected. So I would probably agree that lid erythema would likely be a common symptom. But however, with respect again to the studies that I've read, it wasn't there, but I feel like that would make sense.
Yeah, there was a nurse who reported on lots of the patients, some of the early patients at the nursing home in Washington, who talked about the fact that all of the sick patients had that red lid appearance. It didn't look like conjunctivitis to me. It looked like red lids. But again, that's very anecdotal.
Yeah, and I have to say too, there's a lot more studies I think that need to be done within our patient population within the United States, because a lot of the stuff that's out there now is really with respect to, China and their outbreak. So I think it would be important to get some of this data as well, officially.
Yep. Thank you, Dr. Poirier. Dr. Beaton, you mentioned that there hasn't been an evolutionary need for the virus to mutate much. Do you think one vaccine for it will last, or do you think it would become like the flu, or a new strain would have to be made yearly?
I think that this is not at all like flu. Flu has two different ways of changing. Small changes occur by antigenic drift, and that's really what we're talking about with coronaviruses here. And again, because they do have this ability to spell check, I think there's not a lot of antigenic drift with coronaviruses. So I think if they get an effective vaccine, it will work. And again, my concern is whether it'll be a sterilizing vaccine, which is not what most people think it will be, but it will be helpful. But no, I think that one vaccine will probably be enough.
I hear there's a lot of talk about azithromycin as well, or in conjunction with hydroxychloroquine.
Yep. So again, there's a small study that's reported the combination of the two of them to reduce SARS in the upper respiratory tract compared with the non-randomized control. But again, very small study. This is not, these things are all being studied right now. We don't really have any clear answers, but you have to also keep in mind that the combination of hydroxychloroquine and a Z-Pak are associated with QT prolongation, and caution is advised when using these drugs in patients, especially because some of them are already very sick. Many of them, because of the comorbidities, often are cardiac related. So it's, you always have to walk a fine line.
All right, we have lots of questions coming in, but I think we're going to stop there, and we'll just get back to these other questions, which is some great questions coming in, but I want to make sure we get to the other parts of our program here that are also important. But we'll stay with this for as long as people want to stay with us. So Betsy, I'm going to hand it back to you, and I can see where we left off on the questions, and we do have probably a dozen open questions still.
Okay, so now I'd like to present Dr. Anupam Lal. Dr. Lal, are you there?
I am. Can you hear me?
I can hear you.
Great.
If you can start to share your screen, I'll confirm that I can see it, and then you can go ahead and start. Thank you for joining us. Thank you, Kim and Dr. Madonna and Dr. Beaton so far. We're going to try to get to as many questions as possible.
Very good. Can you guys see that there?
No, not yet. You want to try again? I can't see your screen.
All right, let me give it a go.
There we go. We're starting to see it.
Fantastic.
Yes.
All right, thank you.
Your slides are up. Great. You're good.
Awesome. Thank you so much. As Dr. Madonna mentioned, I'm going to be talking to you folks in my capacity as the chair of the Infection Control Committee. And really what the whole crux of this here is to maybe give you an idea on some of the discussions that we have had as an institution as we're dealing with this virus. Obviously, our utmost responsibility is to our patients, to ourselves, and the community. So what things can we do on an institutional level to reduce the spread of this virus? And hopefully we can, again, give you some insights on the things that we're doing that maybe you can apply to your offices as well. The way I'm going to break this down is I'm going to talk about administrative controls, patient management, PPE, examination protocols, and then lastly, disinfection techniques. So what I mean by administrative controls is really the idea here is the limiting contact. So what things can we do to limit contact so that, as you know, Dr. Bean mentioned, and as any virus, the virus needs us to spread. So by limiting contact with you, your patient, and others, you're limiting the virus from spreading. Of course, many of us have already done this in terms of rescheduling our non-essential patients. Dr. Brabenzi will talk a little bit about things like urgent care and emergent care. But I do want to bring up the idea of triaging and the appropriate training for staff. So when we were dealing with this a couple of weeks back, the idea here is we had our front desk staff, we had our floor managers, we had the administrative team really talking about what we can do from a triage standpoint so that we're avoiding contact as much as possible to help prevent the spread of the disease. Anything you can do electronically, do it electronically. And also if patients are needing things like solutions or contact lenses, if possible, mail those things to patients. Or, as many of us who live in the New York City area, a lot of our food deliveries and such are providing us with contactless delivery. So that being said, you may want to set up a protocol as such where if patients are coming in to pick up contact lenses, let's say, that the patient may call from outside saying, hey, I'm outside. And you kind of drop off the contact lenses outside the door and they just grab it from there. So again, you're not touching base with them. You're not getting within that 6 feet of your patient. Setting up office protocols. So in terms of protocols, and this will vary per institution, but again, the idea here is what can we do on the front end to avoid that close contact as much as possible. So setting up things like, I've seen this, there's a veterinary clinic in my neighborhood. There's a sign on the door that says, when you're here for your appointment, give us a call. So they're not allowing patients to actually go into the facility and then sit down, in the waiting room and touch every single magazine that's there. They're actually picking up the patient from the outside or having them sit outside. And then only bring them in when you were ready to sort of see them. Also setting up either via phone. So when your patient says, hey, I'm outside, we do a quick screening for COVID. So a questionnaire asking patients about fever, a cough, shortness of breath, some of those newer symptoms like loss of taste, loss of smell. You can screen patients out that way. And you can change what you need to do depending on if patients do answer yes to any of those questions, or if they've been in contact with somebody with known symptoms or the above symptoms. We do this in our lobby area, but again, depending on how your practice is set up, you might want to make it as a single entrance practice, and the patient does have to wait outside, and you can ask those questions prior to them even getting into your practice. Temperature screenings, that's something that Dr. McGovern talked about last week. So that is something that we have started where we do forehead temperatures right now. And we're actually revising that protocol a little bit. And I think Dr. McGovern mentioned that last week. Anything you can do virtually, do virtually. So that includes, paperwork, getting insurance cards, credit cards, that type of thing, payments. If you can do it electronically via Venmo, if your system is set up that you can do it over the phone, where they give you credit card information. And that even goes for not only checking in, but checking out as well. For example, you don't want a patient to be hovering around your front desk staff thinking if, April 30th at 10 a.m. is a good follow-up time, if you can walk them out and then have your front desk staff call the patient and they can deal with that over the phone. Again, you're separating your front desk staff and the patient. You're limiting the amount of people and surfaces that your patient touches. That being said, if it's possible for you to do so, once the check-in process, the virtual check-in process has happened, bring your patient right into the examination room. Like I said, I don't want patients sitting in the waiting area, touching your magazines, touching every single pen. You don't want that to happen. You want your patient right into the examination room where there's minimum contacts with that particular patient. Personal protective equipment. So this is something that a lot of us have heard a lot about. I know Dr. McGovern did talk about this last week. In New York and in many places in the country, we do have a shortage when it comes to PPE and what PPE is appropriate. As Dr. Beaton mentioned, in terms of how this virus transmits, the ports of entry are through your eyes, your nose, and mouth. So the idea here is to cover those type of ports of entry. That being said, at the college, what we do is we have face masks. Some face masks do have visors. If you're not using a face mask with a visor, then I would also recommend goggles. We do have some safety goggles that we tend to clean with alcohol or soap and water. Let them soak in soap and water and clean them that way. Gloves, obviously. And in the past week or two, we've ordered a few slit lamp breath shields. So that offers an extra layer of protection. So as you know, this virus spreads mostly through patients' mouths, breathing. So breathing, sneezing, coughing, that's how it tends to spread. So that breath shield on your slit lamp just offers a little bit more of an extra protection. I do want to note one thing. Obviously, hand washing is important. And follow the proper protocols when donning and doffing your PPE, washing hands before, washing hands after, and making sure that you're not touching those front surfaces and then essentially touching your eyes or your mouth or your nose. So follow the proper protocols as you're taking off that PPE as well. In terms of examination room protocols, obviously, we're in a small room with the patient. So you want to do everything in your power to essentially give yourself a little bit of space. So that might mean that as your patient's sitting in the examination chair, you might be performing the history and some of the preliminary testing, maybe right at the front, at the exam room door. So you're not 2 feet away from the patient. You might be 4 or 5 feet away from the patient if possible. So again, anything you can do further away from the patient, and hopefully in your practices, since it's mostly an urgent practice, you can have the door open a little bit. You can stand at the doorway as you're doing that history, because hopefully, again, there's nobody else in that setting. Only get close to the patient when you're ready for the examination portion. So after I do the things that I need to do, I'm scooting into the slit lamp. That's the only time that I'm getting that 1.5 to 2 feet away from my patient. The majority of my time, I'm a lot further away from the patient's face. I do advise the patient, I do tell patients, for your safety and for mine, during the examination portion, we're not going to talk. So therefore, I don't want patients, again, spreading it through their mouth. We just stay silent for that portion of the examination. As always, in a situation like this, only perform the necessary tests and procedures for that patient visit. What you don't want to do is you don't want to take the patient room to room, OCT, visual field, all these other tests. If we can postpone it, if we can postpone it a month or two, if it's not going to cause a detrimental decrease to the patient's health and vision, then go ahead and postpone those type of things, schedule the patient back. Again, we're limiting the amount of contact time for our patients. We're also limiting the time that the patient is sitting in our examination chair and room. You know, you want to get them out as soon as possible. There are some early reports, and you might have read this, in regards to non-contact tonometry, the air puff type tonometry, because there has been viral particles in the tears. By forcing air on those on the eyes, it could cause those viral particles to aerosolize. So go ahead and use either an eye care or disposable Goldman probes, or if you are using Goldman, follow the proper cleaning protocols using 10% bleach and the proper rinsing and such. And again, only perform tests that are necessary for that particular visit. Disinfection. When it comes to disinfection, this is something that you want to work with your staff on. Have a checklist on what things need to be cleaned and how often. At the college, our facilities team do a clean sweep of our clinic floors every 2 hours. So that includes the elevators, the waiting room areas, all the railings that are on our clinic floors, the bathrooms, common spaces, you know, anything that anybody would touch. We have a protocol where every 2 hours this is happening. And that's something, like I said, you may want to set up with your team and get that squared away. So those type of things are happening, again, reducing the spread that way. This is an exam room cleaning protocol that I wrote up for the college. And as you can see here, this is something that was sent via email to all of the providers within the college. We just happen to use Clorox wipes and then Cavi wipes. And for those two types of wipes, the minimum contact time was 4 minutes. However, I do have a link on that here for a full list of approved cleaners and the amount of contact time. So the contact time does differ depending on the cleaner that you're using. So make sure that you do consult with the list so that you know how long something needs to be cleaned up for. But as you can see, there's a lot of things within the examination room where your patient, should they cough, sneeze, or breathe on or touch, you can see that those type of things need to be cleaned because they could be a vector for the virus. So that includes, you know, door handles, knobs, light switches, countertops. People usually tend to forget the keyboard and mouse. A lot of us use an EHR system, so using alcohol swabs on keyboards and mouse. The 4-opter knobs, BIO knobs, slit lamp, even the arms of the slit lamp, you know, the little knob underneath that allows you to move your slit lamp up and down, things like that, where some of us don't routinely clean those type of things. In these cases, you may want to pay extra attention to those type of spots, including your fundus lenses as well. So again, give that a go. I have a list, and a lot of companies, whether it be Heino, Welch Allyn, on their websites, they do have proper disinfecting protocols on there. So never hesitate, just go onto their website and look to see what the proper cleaning protocol based on either the slit lamp or the BIO or the handhelds that you have to make sure that you're following the manufacturer's recommended cleaning protocols. Again, you know, it's one of those things where there's a lot of knobs, a lot of things that we touch during an examination that we may forget, you know, whether it be sort of like the PD on the top here, or whether we click on the light switch or move the arm. I mean, there's so many things that we tend to touch, or the patient tends to touch. As you bring the slit lamp in, most patients sort of grab that table and then bring it towards them. Make sure you clean the edges of the table, the underneath of the table where the patient was holding. So be mindful of that. Anything either you or your patient could have come in contact with, you may want to spend a little extra time cleaning those out. And I always tell my patients before I bring them in, I say, all right, I'm going to go ahead and clean off the instrumentations, and I'll be calling you in a moment, so that I go ahead and do that whole process, wait the 4 minutes of contact time, and then bring them in. And then I go ahead and do the exact same thing afterwards after they leave as well. So before we go here, the things that you really need to, you know, consider, of course, this is just common sense type stuff. You know, keep washing your hands. That's very, very important. You know, use the appropriate PPE. And if you're sick or not feeling well, or if anybody on your staff is sick and not feeling well, don't come into work. The DOH does recommend healthcare workers and staff check their temperature before and after each shift. So that's something that I've started doing myself. And now that we have a temperature, contactless temperature gauge at the lobby, you know, I come in the morning and I have the physician that's manning the desk to go ahead and take my my temperature as well, so that I'm being vigilant in terms of that. And then have regular meetings and updates with your staff. As Dr. McGovern mentioned, there's a webinar that the DOH, the New York DOH, tends to have every single week that has a lot of good updates to it. And I work closely with Dr. McGovern in terms of these new developments that tend to happen. And then, you know, have weekly meetings with your staff so that if, you know, should something need to change in the protocol, that everybody's up to speed. So before we leave here, I just want to give you a list of resources. So these are available here too: the CDC, the WHO, Academy of Ophthalmology, the American Optometric Association. We even have some information on our website as well. So as always, I mean, if you do have any questions and such, these are great resources, or reach out to any of us at the college and be more than happy to touch base. Awesome. All right, that's all I have. So I'll throw it back to Betsy.
Thank you, Dr. Law. I really appreciate you taking the time for today. And now we're going to move on to our next speaker, Dr. Matthew Pavenzi. Dr. Pavenzi, if you can take it over. Are you there? Pavenzi?
I'm here.
Oh,
can you see my
okay,
screen?
Great.
Sorry.
I can see your screen.
Sorry about the mute. Yeah. Okay.
No worries. It's okay.
All righty.
All right.
So
I see your screen, so we're good to go. Thank you.
okay, great. No problem. All right. So so that was a good segue into, Dr. Law discussed how we should be handling patients in our office and the proper infection controls there. And so the question really is, what patients should we be seeing in our offices? You know, as healthcare practitioners, we have a responsibility to maintain the eye care of our patients. Many conditions don't need to be seen directly, but there are some that should. So let's discuss who should and shouldn't we be examining during this crisis. So really, we are juggling kind of between two sides of a coin, the risk of examining a patient versus the risk of not examining. So when we discuss the risk of examination, we have to take into account what is the risk to that patient to get COVID or to infect others with COVID-19 if they had it. So as we know, older patients and patients with autoimmune conditions or diabetes, hypertension, other systemic conditions are more at risk for the virus. They're high-risk patients. We also have to consider their commute while they're commuting to your office. Are they commuting by car and they just be driving themselves, or are they going to be taking the subway and exposing themselves to potentially many more people? And then you have to think about the risk to yourself and your staff. But of course, by taking the appropriate precautions that Dr. Law discussed, you are mitigating that risk to some extent. And then there's the risk of not examining. And so when we evaluate that risk, we should be thinking, how severe are these conditions? Can the patients continue their activities of daily living, even with the conditions that they have, if they're not being examined and treated or managed for them with an in-office visit? And is there any risk to permanent vision loss? So you have to weigh those yourself. Like ultimately, it's a decision that's up to you. And over the next slides, the slide deck I have here, we'll discuss how we can make that decision. All right, so we'll kind of go anterior to posterior and discuss different conditions that may present to you either over the phone or in person, and why you maybe should or shouldn't see these patients. So the first one's swollen lids. So really we're looking at cellulitis versus a hordeolum versus atopic dermatitis. Hordeola, chalasia, and atopic dermatitis do not need an in-office visit. You could probably do this over telehealth, okay? If you have a platform where you can, especially if you can see over video, or a patient sends you a picture of their eye, it's pretty easy to diagnose a hordeolum. And especially if you ask the patient to touch it, to palpate it themselves, and if it's sectoral, we know that's a hordeolum. What you have to be worried about is is it the entire lid? Is the entire lid tender? Then you have to suspect a cellulitis, and you probably should be seeing cellulitis. You know, you really need to rule out an orbital cellulitis, because that could really be serious to the patient's health, not just to their eyes. So really it's the cellulitis patient that you would need to see, and the way to phone triage that again is it affecting the entire lid? Is your vision affected, and so forth? If it's just tender in a small area, you can probably assume a hordeola, especially with other guiding questions. If it's not painful, obviously that's probably a chalazion. And if it's very itchy, then you could diagnose an atopic dermatitis over the phone, and probably does not need to come in. You could just prescribe, you know, a topical steroid to rub on the lid, and they'd be fine. All right, moving on. Red eyes. So most red eyes probably don't need an in-office visit, with maybe one exception. So, you know, and this could all be through telehealth, through guided questions over the phone. Is the predominant symptom itching, especially now that it's springtime and, you know, the flowers don't seem to be affected by COVID. So, you know, pollen is definitely out. So more patients are presenting with or calling in with symptoms of allergic conjunctivitis. That does not need a visit. That patient just needs anti-allergy drops, and you can prescribe them over the phone. Ask the patients about the discharge. If it's mucopurulent, obviously you're assuming that's bacterial. If it's watery, you're assuming that's viral, you know, both of which don't really need an in-office visit. You know, you can prescribe an antibiotic electronically, and for the viral conjunctivitis, that patient should probably stay home anyway, doubly so, right? And be distancing themselves from others. Laterality obviously is important. We know for sure that viral and allergic conjunctivitis tend to present bilaterally. Bacterial tends to present unilaterally at first. Is it sectoral? Is it just red in one area? Because then you might be suspecting an episcleritis, which also is very mild and doesn't need an in-office visit. But the real big one is if it's associated with pain and photophobia. If that's the case, then you really should probably see those patients, because you need to consider a uveitis. And I think the risks of not treating a uveitis or not seeing a uveitis may outweigh the benefits of keeping that patient home. And we'll talk about that later as we go more posterior. Okay, corneal abrasions. So this should be phone triaged. You know, first get the history over the phone. Was there a history of ocular trauma? Did something happen? Did a fingernail scratch the eye, and so forth? And is the vision loss? Is there vision loss? Is there vision decrease because of it? Is it, you know, centrally located? I mean, although you could probably prescribe a topical antibiotic cover and artificial tears to help with the abrasion, I think this is a patient that you should probably see to make the diagnosis and determine the necessary treatment of, particularly because if they have symptoms of an abrasion, but they didn't have any ocular trauma, you might suspect herpetic keratitis, which of course would have similar symptoms, but obviously a very, very different etiology, and that would need, you know, antivirals. And the only way you are going to be able to diagnose a herpetic keratitis would be an in-office visit to stain the cornea, look for a dendritic lesion, and so forth. So you should see these patients. Okay, patients with uveitis. So the risk of no visit could be moderate to high. And of course it varies to every patient. In some patients, it's maybe no big deal, but in others, synechiae could form. There could be IOP elevation if there's a trabeculitis associated with it. You know, of course, if it's a cyclitis, then the IOP can be lower. But if it's higher, then you could have an IOP elevation that should be seen and treated for. If the patient may be in pain and discomfort for a long time if this isn't treated and addressed appropriately. You know, and you probably shouldn't be prescribing steroids. Topical steroids on, you know, without examining first, if you haven't seen that patient before, especially. It's really impossible to diagnose accurately a uveitis and what the appropriate treatment would be without a slit lamp exam. So, you know, if patients are in severe pain and photophobia, that's a patient that warrants an in-office visit. So unilateral pain, photophobia, and redness, especially if the patient, if the patient's had previous episodes and you know them well. I mean, I have a patient actually, chronic uveitis patient. She has a few autoimmune diseases. She has rheumatoid arthritis, osteoarthritis. She has Sjogren's syndrome. She's in her upper 60s. I know this patient well. She just had cataract surgery, and of course she developed a CME as a result of it. And we had an exam scheduled for her, and this would be a patient that I ordinarily would want to see, but given her condition, her risk, I mean, if she were to acquire COVID, she would be very, very high risk. So I'm very worried for her. So what I've been doing is each week I've actually been calling her on the phone from my office and discussing her symptoms, seeing if she notices her vision, subjectively getting any better or worse, with the CME. She's on an NSAID now, in addition to her the uveitis treatment for that eye. But so if you know the patients already and you know how to manage them, you know which patients I'm talking about, the ones where you could call in a steroid prescription and trust them to take it appropriately. But others who you haven't seen before, that you suspect a uveitis, you should probably come in and see. All right, let's talk about glaucoma. So I would say that the majority of glaucoma patients, if they're already known and diagnosed glaucoma and they are stable, and they are in compliance with their treatment and their IOP is well controlled, those visits could probably be rescheduled and put off. You don't really need that 3-month IOP check and annual visual field or annual OCT this month, right? You could get that in 3 months from now. You could get that later in August and so forth. And if you know the patient and they've been well controlled, I mean, the chances that they're suddenly not well controlled are low. Okay, so that's a case where I would refill those meds, and we've been doing that at SUNY, and leaving it up to the providers. But for my patients, for example, and I run a glaucoma clinic at the school, I've been rescheduling my mild, moderate glaucoma patients who are well controlled, who I know are well controlled, and I've just been refilling their meds. Now, what glaucoma patients should you see? Well, if you know a patient has narrow angles, for example, and they call in with signs and symptoms of an angle closure, like pain, nausea, clouding of vision, I mean, that patient's at risk of an angle closure and they really need to be seen. Now, if the suspicion's really high, I mean, maybe you should actually consider sending them directly to the specialist, because that prevents 2 visits, right? They're coming to you, you diagnose an angle closure, then they're going to, an OMD to treat that with an LPI. Of course, you could get the treatment started. Optometrists very well can manage angle closure in office, but we can't ultimately treat the angle closure, which requires an LPI, right? So, you kind of make that decision on your own, but regardless, an angle closure needs to be seen. You should probably have that patient come to your office and see them. And then I would say other glaucoma patients you may want to consider seeing are those that maybe they were out of control. Their IOP was out of control the last time you saw them before COVID happened. You put them on a med and you wanted to see where that went. Especially if they were advanced glaucoma. That's where the risk to their vision might be so great that you might want to see those patients. But of course, those are also probably the patients who are frail, older, and so that's one that I can't make a decision. You have to make that decision on your own, weighing the pros and cons. Likelihood of vision loss versus risk to themselves in acquiring or passing on COVID. All right, diabetics. So most diabetics you could reschedule their annual diabetic eye exam for sure. But I would say if there are vision changes in a known diabetic, somebody has diabetes, especially if the retinopathy is a little bit more severe. You need to consider the things that can cause vision changes in diabetics. So diabetic macular edema, which can occur at any stage of retinopathy, we remember, although it's more likely in moderate and severe and PDR. But then patients who have severe PDR, you have to consider proliferative diabetic retinopathy. If they were already at risk and then they're calling into the office saying, suddenly they can't see, you have to suspect PDR and that patient should be seen. Okay, that's an urgency. Vision changes in a known diabetic. Similarly, vision changes in a patient with known intermediate AMD, I would say. So someone with just mild AMD, stage 1, that patient's visit could probably be put off, right? But somebody with intermediate AMD, so that means, here, I'll blow up this picture. That means drusen that are, you have at least one large druse, so that's 125 microns, the size of a venule, basically, or many intermediate drusen, and that's stage 3 AMD. Those are highest at risk for developing exudative or wet AMD. And so you have to consider a neovascular membrane in those patients. So if someone has, intermediate AMD or worse, and then they call in with vision changes, you should probably see those patients. But I would say if it's anything less than that, mild AMD, and they don't have vision changes, you should probably put off that exam. Artery occlusion or vein occlusion. So the next set of slides are all going to have the same kind of heading. It says any sudden loss of vision loss is an emergency. Okay, so someone calls in and they say, I woke up and I can't see, or suddenly half my vision is gone. That's obviously an ocular emergency, and you need to see that patient. Phone triage the loss of vision. When did it happen? Was it upon waking up? How severe is it? Is it half your vision? Is it your entire vision? These are guiding questions which can help you come up with a likely differential in your head. Are there associated conditions, hypertension, hyperlipidemia, diabetes, and so forth, which all can put you at risk for these things? So, retinal artery occlusion or retinal vein occlusion really need to be seen. We've actually had a couple of those come to us at SUNY. We have urgent care every session at SUNY. So we have a doctor on schedule every session. And we've already had an artery occlusion, a vein occlusion, a corneal abrasion. So all the things I'm telling you about today, we have seen. Okay, sudden vision loss, any sudden vision loss is an emergency. The only thing I added to this slide from the last one is, did they have cataract surgery recently? Because maybe that patient is developing a cystoid macular edema. And they're really the only way you're going to be able to evaluate that is by seeing them in the office and then treating appropriately. Other causes of sudden vision loss, which are emergencies, would be, of course, an ischemic optic neuropathy. And this is really significant, especially in your elderly patients over 70. You need to suspect and rule out arteritic AION, because if that's not treated, as you know, that can cause irreversible bilateral blindness within days. I mean, it starts unilaterally, but if that's not treated with systemic IV steroids, that patient could really have severe irreversible vision loss. Okay, so again, any sudden vision loss is an emergency and should be seen. And that could be with other sources of optic disc edema as well. Now, optic neuritis, if it's typical, there's going to be pain on eye movements most of the time. If it's atypical, it's usually secondary to an autoimmune disease. Vision loss can be anything from very mild, you could still have 20/20 vision in an optic neuritis, or very severe, down to light perception vision. I mean, it really runs the full gamut. I think the majority of patients with optic neuritis have VA of about 20/60 during their attack, but it really could be anything. But again, if there's sudden vision loss, you should see it. It's important to note that other causes of disc edema, like papilledema or compressive optic neuropathy, these patients usually don't have vision loss suddenly. It's usually slow and progressive. So that those patients are unlikely to call in with complaints, to be seen. But of course, if you were examining a patient and you saw optic disc edema, that's something that should be further investigated and worked up for, okay? But again, the only one on this list that would be a cause of sudden vision loss would probably be optic neuritis. And even in half the time, it wouldn't be severe vision loss, okay? Now, these other causes of vision loss are not actually emergencies, but you're not going to know it over the phone, right? Someone calls in with sudden vision loss. That actually could just be posterior subcapsular cataracts that just happen to finally cover their nodal point, and so suddenly their VA went from 20/20 to 20/60 or worse in a day, right? That happens with PSC cataracts. Or PCOs, posterior capsular opacifications. Central serous would be sudden vision loss or recent onset vision loss, which you wouldn't know until you examine the patient. Macular holes, which are caused by VMT, vitreomacular traction. Again, it's going to present as an emergent vision loss, but ultimately they're not emergencies per se, right? That patient with PSA cataracts could put off their cataract surgery for a few months. The PCOs, could put off their YAG laser for a few months. Central serous is going to calm down on its own and so forth, and macular holes. These aren't necessarily emergencies, but urgencies per se. Okay. All right, flashes. This is the last one I would talk about would be like flashes and floaters. So retinal breaks need to be seen. If someone's complaining of recent onset, like new flashes, we all know those patients with floaters who, every year they talk about their floaters, but they're the same floaters. They're their friends that they're used to having for a long time. Those patients aren't the ones that are going to call in for emergency visits. It's the ones who say, I've never seen this before in my life. I have flashes every 5 minutes. I'm seeing a lot of floaters. Those are the patients you need to come in and you need to examine with a dilated fundus exam to diagnose and treat these retinal breaks, because obviously holes, tears, and detachments can lead to permanent vision loss. If they need to be treated and they aren't treated, they could lead to severe vision loss. So that needs to be seen. So in summary, on the left, I put things that should be seen. On the right, things that probably don't need to be seen. They could be telehealth or rescheduled, but these are just guidelines. This is not from a book. This is just using kind of logic and common sense. And you ultimately have to weigh the two things: the risk to the patient of them coming in, and not to mention the risk to yourself and your staff, and weigh that against the risk to the patient, who we have a duty to, by the way, the risk to the patient for not coming in or for not doing an in-office visit. So again, corneal pain, which could be an abrasion or herpes simplex keratitis, uveitis, which should present with pain or photophobia, uncontrolled or angle closure glaucoma, and then anything that could cause sudden or recent onset vision loss, which I've listed some of those things there, and then recent onset flashes or floaters. Those should be seen. Things that shouldn't be seen or don't need to be seen per se: hordeola, bacterial, viral, or allergic conjunctivitis. An episcleritis could be diagnosed over the phone by and large, right? That's going to be painless usually, sectoral redness, but a little bit of discomfort, right? Historically stable or controlled glaucoma, they really don't need to be seen. You can reschedule those patients and just refill their meds. And then if there's slow or progressive vision loss, obviously refractive and binocular changes can wait. Cataracts can wait. Epiretinal membranes can wait. And so that concludes my portion. I'm going to pass it back over to Betsy.
Thank you, Dr. Paventi. I really appreciate you taking the time to present today. Okay, so we're gonna get started and move to our next speaker. But prior to that, I wanted to address something. We have a great deal of questions that have come in, and it's Sunday. We want to make sure that we address all of the questions. So what we're going to do is some of our speakers are going to get on through the question, the Q&A box, and answer the questions via text. As attendees, you are able to view all the questions that have been answered. I just want to make a disclaimer: the questions that have been dismissed are questions that were asked earlier in the presentation and were answered virtually. So understand that the questions asked that are in the dismissed section mean that they were answered already virtually. And then the other ones that will be answered through text. If you want to see what kind of questions are being asked, I suggest you go in there and see the answers that have been done. We are picking a few of these questions to answer them via like this through the talk, but we'll do that after Dr. Snowden's lecture. So I'd like to present Dr. Richard Snowden. Dr. Snowden, are you there?
Yes, I am.
Okay, great. You can start to share your screen when you're ready.
Okay.
I'll confirm that you have it. I confirm that I can see it. All right, we're able to see your screen.
Okay, let me just go back. Okay, You can see the screen, what, okay?
I can see the screen. Thank you, Dr. Mavenzi, and thank you, Dr. Sona. We can see your screen, so you can go ahead and start.
Okay, good evening, everybody. I know last week, I'm not sure how many of you were on the presentation, but I did cover a significant amount of material on billing and coding for telehealth services. Since this 1 week has passed, there has been a tremendous change in the way coding and billing and coverage is going to take place. A lot of the rules have been laxed, so I'm going to try and give a brief overview of those new changes and yet cover some of the important components for those of you that weren't on the presentation last week. And with the disclaimer that this information is as accurate as possible as of this particular moment. Every day there's been another change of what's going on. The AOA in relationship to working with CMS did get optometry included into the waiver, which allows us to do a great deal of coding and billing and providing telehealth services for our patients. We are defined as doctors of optometry for the Medicare rules and regulations, and all the situations and all the billing things should allow us to take place. We did get a major problem from a Medicare carrier in New York City who was reluctant to include optometrists as physicians. He challenged us to do telehealth services, but as of Friday, I did receive this important information that says that Dr. McKinney, who's the Chief Medical Director for National Government Services, which controls most of our Medicare billing, recognized that as part of the public health emergency, NGS recognizes providers, including doctors of optometry, and are allowed to provide non-traditional services via telehealth as long as the services are reasonable and necessary. So that was a good win that we did get. The new rules that have been going back and forth during the week are that CMS, and again, CMS specifically refers to Medicare claims that are going on, is basically that the place of service really should be 11. Last week, I mentioned to you that for Medicare billing, it should be 02. They've changed their mind, basically because if you put down 02, it's going to result in a lower fee. And the emergency law that was passed said that the fees have to be the same, whether it's being done in person or whether it's being done through telehealth. So that's an important thing. Most carriers are accepting the 95 modifier for indicating that the service was done via a telehealth platform. It also seems that CMS is now adopting the 2021 guidelines on E&M codes, which I don't know if many of you are aware of all those new guidelines that are coming in January of 2021, but they seem to have laxed the rules a great deal. The short version of these things are that you can code, or you will be able to code, Medicare claims and probably all commercial claims starting in 2021 based upon the amount of time and the medical decision-making involved. It's way beyond the scope of this lecture for me to give you that information right now. Maybe we'll do it at a later date. And also the other big change was that all telehealth services are now going to be eligible for new patients and established patients. There was only one that was allowed for new patients, but those rules have been laxed. I believe they have been laxed for not only Medicare, Medicaid, and many of the other commercial carriers as well. Just to quickly review, there are 4 types of non-face-to-face telehealth services. There's virtual check-ins, which involve images and telephone conversations, electronically based e-visits, telephone services, 2 types, and telehealth services, which are 2-way bi-directional face-to-face time with the patient, all right? And these should be patient initiated, and everything I read right now is texting is probably not something that you should be doing for billing. So just a quick review, Medicare will pay for virtual check-ins for new and established patients. There are telephone conversations. You have to spend at least 5 minutes, not more than 10 minutes with the patient. That's G2012. That may be for someone who calls you with a red eye and you determine that it's just a subconjunctival heme. Discussion should be greater than 5 minutes. It should not follow an E&M visit that took place in your office. Many of us are not going to be in our offices for a while, so I don't think that falls in, and it should not result in a visit within 24 hours. There is also the G2010 code, which means that a patient can send you a recorded video or an image. You can actually look at that image. An example would be the same conjunctival hemorrhage patient who emails you a picture. You take a look at it and then you call him. There does not seem to be a restriction on using G2012 and G2010 on the same day. I've listened to 4 different lectures on this, and 2 of them said you can and 2 of them said you can't. My understanding from the Correct Coding Initiative is that these can be done. The only carriers that are not allowing this are Medicaid at this time. I believe even many of the commercial carriers are doing it. The Medicare online digital evaluations usually require an online portal or possibly a secure email. These do not involve any kind of phone conversations. Therefore, new and established patients, you're going to use them again. They can't be with a medical visit in the past 7 days. You're going to be using these 99421 codes. They're all specifically time-based, so 5 to 10 minutes. If it's less than 5 minutes, you shouldn't be billing it. You can be doing the virtual code that I spoke about before if it's a very, very brief thing, or if you're going to be doing it for 11 to 20 minutes, it's a little bit higher with a different reimbursement and so forth. When it comes to telephone services, where you're really just talking on a phone to a patient, Medicare has changed its rules. They never allowed this. Now, during the emergency, during this particular COVID-19 emergency, they're going to be allowing these non-face-to-face evaluations if you have an ability to talk to a patient. The codes are 99441. They're E&M codes. They go based upon the amount of time that you spend with the patient, 5 to 10, 11 to 20, 21 to 30, same times that you did with the electronic version. The 4th is the face-to-face two-way communication. It includes office visits for us. Patient is not, the provider and the patient are not in the same room. The patient can be in his home. The provider could be in his office or a remote location like the provider's home. There has to be live, interactive, two-way communication, audio and visual that's bi-directional, all right? You can use Skype, you can use FaceTime. All of those are not secure websites, but during this emergency, they can be done. The only thing I would avoid using is a public-facing platform. You don't want non-seeing patients involved in the care. The originating site is the location of the patient. The distant site is the location of the provider. Here are the codes that you can use. Note 99 I codes are not included. Use modifier 95. Place of service, as I mentioned in the beginning, should be at a number 11. Commercial carriers and Medicaid may be different. And this has to be synchronous things are going on. So for this type of service, it's 99201 to 99205, 99212 to 215, real-time, standard office visit documentation. Documentation for all telehealth services should have a statement that the person is accepted a telehealth service and he knows that you're doing this through a telehealth system. All right, bill it with 95, place of service should be 11. Now, when you're billing the 9900 code, specifically, you had to reach certain levels of understanding for what was going on, a certain level of history, a certain level of examination, and a certain level of medical decision-making. And if more than 50% of the encounter was done based upon counseling or coordination, you could bump it up. Again, verbal consent, you may want to have written patient-initiated request for care and consented to care by telehealth. An example might be a patient with a visit for an allergic conjunctivitis. You do a video call with the patient, bi-directional, you both see each other, you include a chief complaint, a virtual exam, you discuss treatment options, and you advise them what to go on. Here are the rules and regulations for the 9900 codes. Again, it appears that Medicare and Medicare only is using those 2021 guidelines, which probably many of you are not aware of, which you can base it on the time and on the medical decision-making. It's my contention that for this service, unless you're doing it with those new guidelines, you probably can do a 99212, maybe a 99213, possibly a 99202 for a new patient. A lot of the HIPAA rules were changed. Here's a quick overview. Many of the private insurance companies are applying the same rules. They may use different modifiers. It's always best to call and speak to them directly. Some of them allow the 2010 code. Very quickly with Medicaid, Medicaid has always covered synchronous telehealth services since February of 2019. They are now covering the telephone services during the coronavirus epidemic. They at this time, and I tried to get an answer today and I haven't gotten one yet, that they don't cover the G codes. The managed Medicaid program should be similar. Again, they may use different modifiers. You may want to check with your malpractice company to make sure that telehealth services are covered. For those of you that have the AOA policy, it's written in there. You really should decide if you want to offer your patients telehealth visits. It's highly recommended that you do. And if you're in your office, you block out time. If you're not in your office, you can do it from your home. Standard documentation should be maintained. You need that consent. And you may want to also update your voice message and send the patient to everybody. And on the availability of telehealth, update your websites are going on. So determine if you want to do it, get a dedicated space, and take care of everything else that's going on. The last thing that I did want to mention when it comes to Medicare, and this is not a coding and billing thing, but for those of you who are on the phone with practices, Medicare is allowing an accelerated and advanced payment. You should go on the National Government Service website to understand this, but they are willing to upfront you 90 days worth of billing in advance based on what you did for the past 120 days or a period around that time. I think it's actually 180 days. So if you're cash strapped and you want to be able to borrow money from Medicare for 90 days, there's an application online. This is not a forgiveness loan. You have to give this back within 120 days. They may take it off for future claims. And I think if you don't do it within a certain period of time, you're going to have to pay some interest. But it's something that I just learned about the other day. It's on the National Government Service website, and you can look for that if that interests you. It's nationalgovernmentmedicare.com. So again, I know that we had lots of questions last time. I appreciate you taking the time to listen to this. And if you have any questions, please feel free. Thank you.
Thank you, Dr. Sullivan. I appreciate it. Okay, so we're going to get to the questions area. I think some of the speakers have gotten to some of the questions via text. I do want to make a few remarks. The recording of tonight's webinar will be provided to you. It will take me a day or two to make some edits on it. I will send it to everyone via email. And if you don't get it, email us and I'll send it to you along with some of the presentation, because I know along with some of the slides, because I know those questions were asked about some slides, especially the billing and coding. So I'll try to gather all of the slides and send them to you. Okay, Dr. Madonna, if you want to chime in now for some of the questions that you've selected to answer live.
Okay, thank you, Betsy. Am I coming through?
You're welcome.
Yep, I guess.
Yeah, you're coming through. You're good.
All right, so it's 6:47. We'll make a hard stop at 7 o'clock, 6:48. So I'll pick a few that seem interesting to me. So I guess I have some editorial comment on some of the questions, but we're hoping to get to all of the questions via text. I mean, we still have about 40 questions we're sitting on. So here's one.
Sorry, Dr. Madonna, ma'am.
Yeah.
Sorry. And the last thing is I will include the question box as part of, like, the answers and question box with the attachment. So you will see the written answers part of the attachment. So go ahead, Dr. Madonna.
No, right. That's a great point. Thank you, Betsy. I hear there's a lot of talk about azithromycin as well, or in conjunction with the hydroxychloroquine. Will anyone address that, please?
This again, it's controversial, right? So there's not been a really great study of one without the other, or so it's yes, there is anecdotal evidence from this guy from Rockland County that he cured himself using a Z-Pak and Plaquenil, but until we have really more evidence, that's not, nobody really knows, honestly.
Yeah, unfortunately, that's the answer to a lot of these questions.
Right, exactly.
Kind of a follow-up, or well, it's not really a follow-up, but it's kind of along similar lines. Isn't IV vitamin C starting to be used?
That's had its day too, with even with the common cold. So again, no controlled studies. We really can't say, probably can't hurt you because vitamin C is water soluble. So whatever you don't, you're going to just pee out. So there you go. There's just really no evidence.
This one is for Dr. Lal. What about N95 masks?
Yeah, I mean, that's a great question. So, as everyone knows, the N95 masks are somewhat scarce. At this point, it's really hard to come by. We have a couple at the college. However, again, the only time we would ever use anything like that is if we had to treat a patient who we had high suspicion for that had the COVID virus. So on our regular patients who answered no to all of our questionnaire questions and their temperature was normal, those patients, we just wear a regular surgical mask. But mind you, wearing a surgical mask, spending your distance away, using things like a breath shield, a splash guard as such, does offer, of course, pretty good protection. The N95 masks, the big benefit of it is that it's a very tight-fitting mask. You have to be clean-shaven in order to use it, and it does not allow those small particles, particularly in a hospital setting where you're doing things like intubation, where you can get a lot of these fine particles, coming at you. In our type of setting, we usually don't see that. So the need for an N95 is actually relatively low.
Thank you, Dr. Lal. And I got a couple. We'll just keep going because
Sure.
There's a few that are directed at you. Are you advising clinicians to wear scrubs?
So that's actually a really good question. This sort of came up last week. In terms of how the virus tends to adhere to clothing, it depends on materials. The reports say that it can last anywhere from a few hours to about a day worth. The good news here is that regular soaps, so just as your normal laundry detergent, it's a soap, it can actually kill the virus. So normal laundry, tends to do the trick. So that being said, we don't have a policy that we recommend everybody wearing scrubs. Most of our clinicians do wear clinic coats, and then we do recommend the normal laundering. However, we do have some clinicians who do prefer to wear scrubs during this epidemic as they're seeing urgent patients. So we kind of leave that up to the individual docs. But like I said, it can last anywhere from a few hours to about a day or so on clothing, depending on the material.
I have a few questions on disinfecting, so I'll just ask them all as one, and maybe you can comment.
Yeah.
Are alcohol wipes sufficient to clean probes when doing applanation tonometry? Are alcohol swabs enough, or should we stick to Clorox wipes? Probably not necessarily for the tonometer tips. Any thoughts on hydrogen peroxide? And how about Lysol and letting it air dry? So that's kind of a bunch of them.
Sure. So we know that alcohol, 70% alcohol and above, does denude and denature the virus. So that being said, it is an effective method. So using alcohol swipes on tonometer probes and other portions of your, say, slit lamp or keyboard or whatever else it may be, is actually very, very effective. One thing to note about tonometry, though, is that if you look at the manufacturers' websites, they actually recommend peroxide and bleach. And I think most manufacturer websites recommend peroxide and bleach. So technically, sure, you can use alcohol on your tonometry probe, but as per manufacturer's guidelines, they do recommend peroxide or bleach. And so what was the other?
Lysol and air dry?
Yeah, and again, it's The last time I checked the list, so if you saw from my slide, the EPA has a list of cleansers which are approved. Lysol was approved. I don't remember the contact time. Most of the cleansers have anywhere from a 3 to 5 minute contact time. And what I would recommend is if you look at your particular Lysol bottle and then go on to the EPA website, because there's many types of Lysol, find your particular bottle, and then it will let you know the extent of contact time and if it is an approved COVID cleanser. So again, good question.
Thank you. Yeah, here's an interesting one. Have you heard of the cocktail of zinc sulfate added to azithromycin and Plaquenil? Dr. Zelenko says he has used it on hundreds of patients rather with COVID who are COVID positive, had survived with no hospitalization or need for ventilator. There was a story about him in the Times yesterday or the day before. And I know you read plenty. I bet you read that article.
Yep, pretty much the same answer that we've had. Like that is anecdotal evidence. There's no studies, no controlled studies. So that's something we're just going to have to hang on and wait and see.
Thank you for that. How about this one? Will we expect to slowly go back to routine or faster? How can we better prepare for the future? That's an interesting question that I doubt has an answer, but Anne, you want to fly in from your end?
I think we need to pay attention. That's what, public health does. That's what epidemiologists do. They pay attention not only to what's happening here, but what's happening across the world. And they did pay attention. They knew this was coming. It was a wave and we were not prepared. The entire, public health team from the White House was, gone. And so, I think that if you look at actually in today's Times, there's actually a great article about Finland. Finland prepared for, their ongoing wars with Russia, and they had tons of stuff that they kept forever and ever. They didn't get rid of it. And they are extremely well prepared, and the incidence is very, very low there. So how can we prepare? We have to prepare by being prepared, right? So you can always look back and say we had too much stuff, but then you can say, well, it's better to be over prepared. So there's really just nothing, more than that.
There was one here and it slid away. Where did it go? It was sitting right there. It was about, it was for Dr. Bavenzi. What's that?
It could have been answered.
It's been answered. Okay, yeah. So there's a going off.
I'm assuming if it's not
Maybe I've been going through them and answering them.
Okay, Matt, you want to talk about the one about seeing two doctors that I think you just answered?
Yes.
Yeah. Why don't you grab that one?
Yeah, that's a good one. So somebody brought up many of these conditions we can't actually do anything about. So why are we sending the patient to two different doctors? And I see your point. That is a valid point. However, if we leave all the emergent care, if we send every patient that is complaining of sudden onset vision loss to an ophthalmologist, they will be overwhelmed. We have more optometrists in the state than ophthalmologists. And although the patients that they could treat, say like diabetic macular edema or retinal tears or angle closure, although they will get those, they will also get the ones that don't need a surgeon's care, like central serous retinopathy or ischemic optic neuropathy. I mean, there's nothing they're going to do for an AION patient that you wouldn't do. There's nothing they're going to do for a CSR patient that you wouldn't do. And so we are easing the overall burden on the healthcare system if we see patients complaining who complain of sudden onset vision loss. I mean, it's true, we will get some who ultimately need to go to a retinal specialist for treatment, but we will get others who we could handle. And I think it's important to handle those when you can.
Yeah, I would totally agree.
Thank you, Matt. Oh, I'm sorry, Kim.
Oh, no, yeah. I totally agree with you, Dr. Bavenzi, as well. So if we can act as much as the gateway as possible, for our ophthalmology colleagues. Even though we work with the retinal specialist really closely, and he's very grateful for a lot of the patients we've been able to kind of field for him, because he's very, very busy, because he's still constantly treating patients, injections. There's a lot of, other treatments they're doing. So they're very appreciative if we're able to, field and triage some of these cases for them.
Thank you. We still have a bunch of questions. So, but it's 7 o'clock or just about 7 o'clock. So I think it's time to stop. So,
hey Rich, can I just say one thing?
Yeah, of course.
I just want to, I went over this very quickly, but the issue of the Medicare director in New York State was really a very combined effort between the AOA and the NYSOA. That's the beauty of having a national association to go to when issues arrive. So I put a plug in for them.
That's fair enough. And the AOA has done a magnificent job, and the NYSOA have done a magnificent job throughout.
I wanted to put a plug in for that.
No, fair enough. That's fair enough. So again, as I'm going to hand it back to Betsy in a second, but I just want to thank all of the speakers for their expertise and time on a very short turnaround. We will get to all the questions, and that's even adding more time to what they've already given. And I appreciate everybody who asked that. We must have had 50 or 60 questions tonight. So we really appreciate it. We will try to look to do more programs coming forward. We also recognize that people are looking for continuing education that could meet some of their requirements. We're looking to take care of that. So Betsy, I'm going to hand it back to you and you can finish up.
Okay, sounds great. I'm going to thank everyone as well and all of our speakers who took the time today to join us. Not sure what that background noise is. Sorry about that.
It's the 7 o'clock cheering for 7 o'clock cheering for the healthcare workers.
Oh, great! Yeah, that's awesome. Oh, I was trying.
I'm gonna clap.
Me too.
Yeah, it's yeah.
So I just wanted to answer, I know I got a lot of these questions myself. I will include the recording link from last week as well as this week. I am going to try to extract all of the questions and answers as well as the ones that were not answered, and try to get our speakers to answer those to you as soon as possible. It's going to take me, a little time because I have to send them the questions and get the answers. And I want to make sure that it is in a clear and concise place and you're getting it in one shot. So give me, 2 to 3 days to compile all this information and all of the links together so I can send you everything you need. And if you have any questions, shoot us an email at ce@sunyop.edu and we'll try to get all of your answers, any questions answered. In regards to upcoming programs, so on Tuesday we have our Asconi program. It is virtual. The registration link, I believe, is on our website. If it's not, I will update it. On top of that, we do have a webinar scheduled for Wednesday, I think it's April 16 or 15, and I'm sorry I don't have the day in front of me. Our office does have, we had planned to give a pediatric symposium in May 31st. We do plan to move forward with that program. In this case, it will be virtual, very similar to our Residence Day program. In regards to CE, I will provide information. As far as CE accreditation, I will provide information with those programs. And without further ado, I will log off tonight. Thank you so much for joining us. This was a great program, and I appreciate everyone who joined, all of our speakers and their time. Have a good night, everyone. Take care.
Good night.
Good night.
Good night. Thank you.